All right. Well, welcome everyone to another virtual shadowing session at Hearts for Health. For this one, we're going to be joined by Dr. G. Just as a quick introduction, Dr. G is a critical care anesthesiologist at Mass General in the New England area. She has her own YouTube channel and blog where she provides medical student resources, a specialty series, and just more insight in the general specialty of anesthesiology. It's a great place to connect with her, learn more from her, and just in general hear more from a day in the life or information of the specialty with Dr. G. So if you happen to be interested about more, feel free to go over there. I think we linked it actually on our Instagram post earlier, but I think that really will wrap it up for an introduction for Dr. G. She'll continue with more of an introduction over herself and the specialty with her talk. But just as a few quick reminders for those listening in, we will have a Q&A at the end. This Q&A will be a time for any questions that we have in the chat. So if you have any questions for Dr. G, any questions for advice, just what the specialty is about, really anything spanning this talk here for shadowing, feel free to type them in the chat and we'll cover them during the Q&A towards the end. And for future shadowing sessions, if you're new to the shadowing sessions that we have here, we update the Instagram page that we have with more posts. So you'll be able to see the upcoming sessions for each week. We post that at the beginning of the week, and then later on the week on a weekly basis on Thursdays at 7 p.m. Central Standard Time. That varies though if you're on the East Coast or the West Coast. But for Central Standard Time at 7 p.m., we'll be having regular shadowing sessions, but we'll let you know about the details of each speaker through our Instagram page. And I think that really wraps it up. If you're interested in more shadowing sessions, you can view all of them that are available on our website's homepage. So we have all of them going through May at this point for shadowing sessions, and we'll continue with more in the summer. But I think that really wraps it up. So Dr. G, feel free to take it away.
Great, thank you for that introduction. Welcome everyone. I'm really excited to be able to share with you about my specialty in anesthesiology, and very rarely do people realize that we actually can be intensivists, or that means that we can also work in an ICU. So with the pandemic, it sounds like more and more people understand that ICU doctors are pretty important people too. So just to delve in, a little about me. So while I'm currently in Boston, I'm originally from Metro Detroit, and I would consider Metro Detroit my home, and Michigan kind of my home. I did some funny things. I actually dropped out of high school to go to college early. So I went to an early college in Western Massachusetts called Bard College at Simon's Rock, and then transferred to the University of Michigan and actually have my engineering degree as well as a master's degree before going to medical school as part of the charter class at Oakland University William Beaumont School of Medicine. Now that there are new medical schools popping up left and right, I will say that that's one area that I love giving advice about too. So if that's something you're interested in, always feel free to reach out about that. But basically, I like to do things in a non-traditional pathway. To keep going, so after medical school, I matched in my top choice programs. My internship was separate from my anesthesia residency. That happens for certain specialties, so things like ophthalmology, radiation oncology, some radiology programs, and anesthesiology. Dermatology is also included in that. The internship can be a separate program from the actual training in the specialty. So I did 1 year in downtown Detroit at Henry Ford Hospital, and that was my internship before I moved here to Boston in 2016 to join Mass General for my anesthesia residency, which was 3 years. I spent 1 extra year to do critical care training so I can be an ICU doctor as well as my anesthesia role in the operating room. And then I stayed on, which is my current job, as a critical care anesthesiologist at Mass General. Now, a lot of people feel like they know the answer to this, but I thought I would give more of a formal definition of what do anesthesiologists do. Well, our society defines our role as individuals that evaluate, monitor, and supervise patient care before, during, after surgery. We deliver anesthesia, and we lead anesthesia care teams to ensure optimal patient safety. We specialize in anesthesia care, pain management, and critical care medicine. Now, I said I'm a critical care anesthesiologist. So just to go into that definition, we supervise, coordinate, and manage the patient's care with the ICU team and work closely with our surgeons and other specialty consultants as needed. What I will say is that what that looks like for my job, for example, is that, for example, today I was in the operating room in an offsite area called the interventional radiology. So I provided anesthesia today with some CRNAs and a resident that I worked with and to ensure that these radiology procedures can get done. Yesterday, I was in vascular surgery, so I did completely different kinds of anesthetics for those patients and worked with different surgeons. But last week, I was in the ICU, so I actually was not in the operating room at all. I was on an overnight shift with my ICU where I cared for 20 critically ill patients, ranging from COVID patients to surgical patients that needed critical care attention. So my month and my week can be very different depending on my schedule, but generally I spend about half my time in the ICU and half my time in the operating room. Something that I like to bring up as well, because it's interesting to be able to explore gender breakdown in various specialties. Actually, anesthesia is still pretty male dominated. So that's something that I like to bring up. It's interesting to see kind of the evolution of different specialties and how gender have changed or play a role in individuals deciding to go into a specialty. So if you are a woman interested in medicine and becoming a physician, definitely consider anesthesiology because we need more women. And we need more men too. So the question of how to become an anesthesiologist. Well, I alluded to this earlier, but in general, to become a doctor, you need a college degree and you need to go to medical school. Now, to specifically become an anesthesiologist, internship is 1 year. It can be combined with the 3-year part. So there are some residency programs that are just packaged as a 4-year thing. And then if you decide to do fellowship, which is an optional thing, that's an additional year. Something that people rarely realize is that anesthesiologists can go into various subspecialties. So for example, cardiothoracic anesthesiology, that's the anesthesia provided for things like open heart surgery. If you watch TV and hear people have a heart attack and they have something called a CABG, that is open heart surgery. So cardiothoracic anesthesiologists learn how to do specialized skills in order to take care of those patients. I myself am a critical care anesthesiologist, and I kind of went over that already. Neurosurgical anesthesia is the care of patients getting brain surgery or other kinds of surgery related to the nervous system. So that can also mean related to the spinal cord and the spine itself. Obstetric anesthesiology, this is actually the majority of the time, the first time that individuals encounter an anesthesiologist is when women are undergoing labor. So a really important role of an anesthesiologist is to provide an epidural or provide basically pain management in order to make the process of delivery of a child much more humane. So that's one area that is really gratifying and that we are very, very present and available for. Another thing that's interesting too in obstetric anesthesiology is that C-sections or the delivery of a baby via a surgical approach can be done completely awake by providing a special kind of anesthetic, which we will talk about in a little bit. So it's a really cool area of anesthesia. Pain medicine. So people don't usually realize this, but anesthesiologists are super comfortable with pain medications, different kinds of pain medications. For example, I had a patient today that had sickle cell disease and had many pain crises and was on a lot of narcotics or opioid medications. Now, currently we do have an opioid epidemic and issues with overuse of opioids. However, there are definitely instances when opioids are the appropriate pain medication for a patient. And in this particular situation, the patient was on a lot of opioids at home. And because of my understanding of opioid tolerance and different conversions for opioids, I was able to help the patient get their pain under control when it wasn't adequately controlled earlier because the doses that were given were way too low. So that's one area where we're very, very comfortable with that. Pediatric anesthesiology, so you do need specialized training in order to take care of kiddos because their physiology, that means the way their body runs and works, their organs work a little differently than adults. So there's specialized training that needs to happen there. And then palliative care, so patients that are at end of life or need to talk about kind of what end of life could look like, we can also do fellowship training in that specialty. People often ask me, What does my actual day-to-day look like? Well, let's talk about the operating room to start. My shifts at my particular hospital are 7 a.m. to 5 p.m. So today was one of those days where I worked 7 a.m. to 5 p.m. Now I usually get to the hospital before 7 a.m. so that I could change into scrubs, but around that time I go ahead and go to see my patients in the preoperative area. So patients that are getting ready for surgery, they go through various areas, but the place right before they come into the operating room and get anesthesia is called pre-op. So I generally am overseeing more than one room. I can also oversee a single room and take care of the patient all the way through on my own. But typically the anesthesia care team model includes nurse anesthetist students, and residents. In certain states, we also have anesthesia assistants. So if you're not kind of dead set on going to become a doctor, definitely consider some of these other routes. And if you like anesthesia assistants, or going through the nursing route, becoming an ICU nurse and becoming a CRNA or certified registered nurse anesthetist is another great route to be able to work in the operating room and provide anesthesia. But that being said, in the morning, I go see my patients, I make sure to assess them, and I talk over the plan with my team. Once we're ready to go into the room, in my particular hospital, we start surgery at 8 a.m. or 7:45 a.m. In other places, they start even earlier than that. So what I found was that as an anesthesiologist, you don't have to be a morning person, but it's probably better if you are a morning person. And I personally became a morning person after I became an anesthesiologist. So don't be concerned if you're interested in anesthesia, you can turn into one later. That being said, we'll start surgery. So I'm generally present for the more important parts of the procedures, meaning the beginning, which we call induction. And if we are going to intubate someone or use any kind of airway devices, I'm present for that part of the procedure. Throughout the procedure itself, the people I'm supervising, so the residents, nurse anesthetists or nurse anesthetist students, they'll be in the room the whole time. But what I will tell you is that as an anesthesia provider, you cannot just walk out on someone that's anesthetized. Now, a lot of people like to think, oh, being an anesthesiologist is just like being a pilot of a plane. You take off and you land, and those are the scariest parts. But there can be some scary things that happen in the middle as well. And as a result, we always have to be vigilant and we always have to be present. You wouldn't want your pilot to walk out of the cockpit completely and rely on autopilot, just like you wouldn't want your anesthesia provider to do the same. And I bring that up because on my schedule here, I put on here AM break, lunch break, and PM break. And what that means is that because I'm supervising, what I'll do is I will go into the room in order for the provider that's in that room to leave the room. So I'm providing them a break. So we can't just walk out to get a drink of water. We can't just walk out to run to the restroom. We actually have to have a scheduled way for someone else to be there when we do that. So a lot of my day is coordinating how to do that with also coordinating being present for important parts of the surgeries. Now, generally I get out at 5 p.m., but I'm also someone that cares for really sick patients. And the most important thing in my mind is that when you go into medicine is that you care enough for the patients to ensure that you have continuity for them. So if I'm caring for a really sick patient, I may not leave at 5 p.m. Sometimes surgeries go longer. Sometimes they get complicated. So it's not always a hard cutoff at 5 p.m. But if it's a pretty straightforward day, anesthesia can be like shift work, and healthy patients are very safe to be able to hand off. So generally I leave around 5 p.m. Today was one of those days where I left at 6 p.m. So I just wanted to make sure I could wrap things up because an anesthesiologist can't just walk out on their patient. The ICU, let's talk about that. Even though my hours are still 7 to 5, they look very different. So in the operating room, if we are to get done a little earlier, I can walk out. But in the ICU, an attending intensivist needs to be present for the entire time that we're there. So even though I'm 7 to 5 in the ICU and the operating room, there is a chance to leave a bit early in the operating room days. Now, when I'm in the ICU, what that looks like is, again, I try to get in before 7 a.m. And once I get in, I get sign out from the intensivist that was on overnight. So I hear about what happened with my patients, some of the things, new patients that have come up, I learn about them. Then at 8:30, we start rounds. So anytime you've been watching like one of those doctor TV shows or things like that, rounds is when we all stand around looking pretty in our white coats and have some sort of computer or device. And we bring the whole team together to be able to talk about a patient. Generally, my team looks like myself as an attending, I'll have a fellow, I'll have residents, I'll have an intern. The bedside nurse in the ICU is one of the most important people that have to be there. I generally have a pharmacist. I may have my respiratory therapist with me. And if there's any other consultants, so other specialties that are interested in hearing about what we're going to do for our patient, they would be present on rounds as well. So it's a big team there. But the most important thing is the goal of rounds is to figure out what the plan is for the patient for the day. So we go over a very, very regimented presentation of a patient in order to come up with a plan. And that's the whole plan, the whole idea of rounds. Now, I put in here around 11 a.m. I'll finish rounds. It really depends on how sick patients are and how many times I've interrupted. In my particular hospital, because the anesthesiologists run the ICU that I am in most of the time, we also carry a special pager. Yes, we still use pagers. If you don't know what that is, please Google it. But we still use these very, very arcane devices in order to communicate. And I apologize, I am in the city. So if you hear honking horns, that's the city living for you. But we use a pager. And what happens is if someone is very, very sick in the hospital, they will send us a page and we will respond and we can go ahead and provide an intubation for them or provide an endotracheal tube so that they can be hooked up to a ventilator. So in the time of COVID, we got called away very frequently to intubate patients. And that was just a common occurrence for us. That was especially in the first wave here in Boston, which was extraordinarily, our hospital took an extraordinarily large number of COVID patients that needed to be intubated. So it was a very busy time. And so then once we're done with rounds, we generally get work done at that point. That means things like writing our notes, calling people, making sure our orders are right, making sure that we kind of progress care. And then we walk around again and make sure everything is updated. And then I sign out at 5 p.m. So that's kind of my day in the ICU. Now, something I often get asked is about this thing called call. So call generally, it happens in certain specialties. Anesthesia and ICU are specialties that require call. Other specialties that don't are generally ones that are outpatient. Like when you go see your PCP or your doctor in an office, that's an outpatient type of doctor. I'm an inpatient type of doctor. So my friend that's a dermatologist doesn't really take call if they're not covering a hospital, but I have to be present, or at least an anesthesiologist and an ICU doctor have to be present in the hospital 24 hours a day, 365 days a year. So we don't get holidays for that. Like we doctors and nurses and medical professionals do have to work pretty ridiculous hours when they're inpatient doctors. Now, you can change that. And what I'll say is when I was an intern, I did a 36-hour call before. Yes, that's a real shift. When I was a resident, I've done many 24-hour calls. There are certain situations in which when you're done with training, you still continue to do 24-hour calls, but not every single job requires that. So I can choose an anesthesia job that does not require me to work nights and weekends or take 24-hour call. But that is something that I like to bring up to people because the reality is you have to survive training in order to get to the end where you become an attending. So call is a real thing. Everyone has to deal with it. Every residency and training program is different on how they deal with it, but it's something to definitely consider is a real thing when you're deciding on the path of medicine that you'd like. Okay. Let's learn a little bit about anesthesia. So in order to shadow an anesthesiologist, you need to learn kind of the things that we do. The most common type of anesthesia people think of is general anesthesia. So that means that someone goes completely to sleep and we use some sort of airway device in order to help them breathe. So it's many patients actually are very surprised when, COVID started, patients would ask me, oh, wait, you're going to put a breathing tube, or are you going to put me on a ventilator? And I was like, yeah, I'm going to put you on a ventilator. We use ventilators all the time, but most patients don't realize that. And so that was an interesting thing that I noticed about with the pandemic is more of my patients have been asking, oh my God, you're going to hook me up to a respirator, ventilator, whatever machine. And I'm like, yes, we are, but we're going to take you off of it, which is different from COVID. So that's kind of this interesting thing that has evolved over time with the pandemic, but generally anesthesia, completely asleep. Now, this is an endotracheal tube, this plastic thing up top. The placement of an endotracheal tube is called intubation. That's the actual procedure that we're very comfortable with in the world of anesthesia. If you see the picture below, that person is holding a metal, yes, it's metal. We use a metal blade to go into the mouth look for the airway and place this little plastic tube in there in order to intubate someone and hook someone up to a ventilator. COVID patients that are intubated do have one of these little plastic tubes in their airway. Another way to provide general anesthesia is actually through this device called the laryngeal mask airway. So this is a little different. This is not completely inside of the windpipe. So if you think about anatomy class, you have a windpipe up in front and you have a food pipe behind it. Now, the windpipe up in front is where we want our devices to be, but this particular one actually just sits in the back of the mouth. And most of the time, patients that get this kind of device are breathing on their own or with very little support from the ventilator. So it's another way we're able to deliver general anesthesia. And honestly, at the end of the day, general anesthesia just means that you have gotten enough medications or anesthesia in order to like not move during pain or during procedures and not be aware of it. So we don't necessarily have to put these airway devices in for you to get general anesthesia, but we typically like to because that's the safest approach to doing it. Another area, another type of anesthesia we provide is something called monitored anesthesia care. And so that is more equivalent to sedation. It is not the same as sedation. One of the things that patients don't really realize is that nursing sedation is actually overseen by the proceduralist. So the first time that many patients come in and get sedation is during their colonoscopy. That's the first time they really encounter nursing sedation. That is completely directed by the GI doctor. There is no anesthesiologist there, and there's no nurse anesthetist there for nursing sedation. However, a lot more patients, many more patients have been asking for anesthesia for things like colonoscopies and endoscopies because they find it to be a little more comfortable. There's not as much of like this hangover effect when we're providing that care. Now, that type of thing is called monitored anesthesia care. It means that we are providing anesthesia, but oftentimes our patients can be completely awake or at least talking to us still. They're still protecting their airway, so we don't put any devices in, and we make sure that they're comfortable and get them through the entire procedure. Another kind of anesthesia technique that we provide is something called a spinal or an epidural. Now, these two things actually go in different places. A spinal is where we put in a very tiny needle into the CSF space. So that's in the space where the brain like squishy fluid is, the cerebrospinal fluid is. So we use a small needle, we get into that space and we put numbing medicine in there. That numbing medicine then numbs up all the nerves until you get to a certain point, and then people are able to actually do surgery with that. Usually that's like lower extremity surgery. So if you get like your hip replaced, your knee replaced, you get any kind of ankle, foot, those types of things, we can do a spinal or an epidural, but we'll go into epidural in a second. But the issue with the spinal is that, and then childbirth, like I said, a C-section can be done under spinal. So that means a patient can be totally awake, interactive, and be able to undergo major surgery. It's crazy. But with a spinal, the problem that comes up is that we enter the space and we put a single dose in there. We cannot redose it. So once it wears off, we're done. We're done with that completely. So obviously it's something that we have to work very closely with our surgeons to make sure that they are done before the anesthesia wears off and before a patient will feel what's going on under this type of anesthetic. An epidural is a little different. I kind of alluded to this earlier. In obstetrics, when a patient is laboring, we place this little catheter in a space that's outside of the dura, which means it's outside of the spinal canal, but it is kind of in that canal area. And we actually put a catheter there. So that means we can continue to give medications. And when we're done with it, we turn off the medications and we pull the catheter. So this means that someone can get pain relief for up to days, because sometimes labor takes more than a few hours. And so as a result, we need something that will last longer and that we have control over. So epidurals can be placed. Now, another thing that is really important in anesthesia are vital signs. So we use monitors in order to obtain vital signs. And some of the monitors that we will obtain include things like an arterial line. So just to go back to our vital signs, just to remind people, vital signs that we keep a very close eye on are blood pressure, the pulse or the heart rate, the EKG, and the respiratory rate, as well as the temperature. So these are things that we are constantly monitoring anytime someone is undergoing an anesthetic, and that's to keep people safe. Now, an arterial line is a special kind of IV. So generally when you go to the doctor, you go in for a procedure, you can get an intravenous line. So that's when you have the little blue veins that you can see. That is a vein. We put a little catheter there. We can give medications. We can draw blood. We can send off labs with that. With an arterial line, that's actually a little catheter or a little straw that goes into an artery instead of a vein. So if you go to the doctor or you yourself decide to feel your pulse over here in your radial artery, so where your thumb is, that is very typically where we will place one of these little lines. And what we do with that is we can get blood pressure every single time the heart squeezes. We can also get labs from it. It is not that big of a deal in terms of a procedure, but it is something that we do very sterilely. And so as a result, it's important for us to actually clean it off and go through a process in order to place it. So it's a little more involved than getting an intravenous line, but it's not crazy involved. It's not like a big procedure per se. We do these very frequently. A central line. So something that many people don't realize is that these IVs that patients will get, we can't put certain kinds of medications through it, because if that medication were to extravasate, that means that if you have a little catheter in the vein blows. That means that the medication is not going in the vein anymore. It's going into the skin or the area. It can actually cause so much damage to the skin that patients need surgery or even need like amputations afterwards. So we always want to be sure that the right kind of medications goes through the right kind of catheter. And a central line is basically a really big IV that will go into a really big vessel. Very commonly, that vessel is the internal jugular vein, and that's something that's right up here in the neck. We'll also do subclavian vein or the femoral vein. So those are the big veins that we can put catheters in. Now, another area in anesthesia that's very important is getting to know drugs and getting to know the good ones, but understanding how they work, how quickly they work when we use it. This is a very, very big part of the work that we do in anesthesia. Okay, let's go into shadowing. So I'm going to present a case to you guys and you can follow along. Generally, when we do anesthesia, we get some information about patients from the electronic medical record. So I'm going to kind of give that information to you. So this patient, his history of present illness, he is a 90-year-old male. He presents with a right hip fracture after a mechanical fall while ambulating at home. So he's walking around at home and he fell over and he broke his hip. This is very common that we see, is a very common type of presentation of a patient for an urgent type of surgery. So past medical history, so PMH is usually past medical history. In short form, he has hypertension, moderate aortic stenosis. Medications, he was just taking metoprolol and lisinopril. Okay. Now, it's very important to do a physical exam because we get a lot of information now from physical exams. Even though we have great technology, we have all these ways to assess patients, the physical exam tells you a lot. So you go ahead and check up on this patient, you find that he is confused. His mucous membranes, meaning like the lips and things like that, are very dry. You can see his lips are cracking. You decide to go ahead and use your stethoscope and listen, and you hear that his lung sounds, breath sounds are clear, but when you listen to his heart, you hear this harsh systolic murmur in the second right intercostal space. And then you also go ahead and assess the hip, and you notice that the right hip just looks bigger than the left hip, but you can push down on it. That's what soft palpation means. Chart review. So, we have this great thing called the electronic medical record. And so you go through it and you find that he has had nothing per os, meaning NPO means nothing by mouth, for 36 hours. He has IV fluids, IVF is IV fluids, running at 75 milliliters an hour. He has received oxycodone, which is an opioid medication, and HGB means hemoglobin, the number of red blood cells that are in his blood, has gone from 14 to 10. This is the part where you rack your brain and you ask yourself, if you were an anesthesiologist, what kind of anesthesia would you provide to fix this man's hip? Now, I'm going to go ahead and move forward. We are going to do general anesthesia, but it is not wrong to say that you could do it under spinal or epidural. We actually very frequently do hip fractures, knees, all those types of things under spinal or epidural, and that patients can be completely awake. But in this particular situation, you decide, because of his past medical history and some other issues, that generally anesthesia would be the safest way to anesthetize the patient. So you come up with a plan. Now, when you learn anesthesia as a resident, you have to call your attending. So my residents will call me the night before and tell me what it is that you are planning on doing for the anesthetic. And generally, we break it down into different components. So lines, meaning how are we going to be able to give the drugs that we're going to give? Well, we can do it using a peripheral intravenous line, a peripheral IV. And another area that's considered a line is the arterial line. And like I said, central line is another type of line. So for this particular patient, we're going to place an arterial line, and we're going to talk about why in a bit. An airway. So you have to ask yourself, if you're going to do general anesthesia, are you going to use an endotracheal tube, that little plastic tube that goes into the windpipe, or are you going to use a laryngeal mask airway, so that little mask that sits in the back of the mouth? Induction is the providing of medications to send someone to sleep. So it's important to pick the right kind of induction medications for a patient. And in this particular situation, we're going to use very common ones, which is propofol. And if you guys don't know what that is, it's a very, very common anesthetic. It is a milky white agent, and it unfortunately killed Michael Jackson because he had a cardiologist giving him propofol. Don't let a cardiologist give you propofol. And phenylephrine is a type of medication to keep the blood pressure up, and rocuronium is a type of muscle relaxant, so that the patients are not necessarily that they're not wiggling under anesthesia, but generally there's muscle twitching that can happen when you are cutting through tissue using electrocautery. So there's a lot of use for using muscle relaxation. So you go ahead into the operating room, you give some propofol, and then the blood pressure is 40/20. I will tell you that normal blood pressure is 120/80, and a blood pressure of 40/20 is basically no blood pressure. So this is very dangerous. And in this situation, you would normally start CPR and give a lot of medications to increase the blood pressure. So you decide, wow, this patient couldn't tolerate just a little bit of anesthesia. So you have a discussion with the surgeons and you say, you know what, I think we need to do something else for this man, or something is wrong. So let's just hold off on the case. Let's go ahead and take the patient to the ICU. And the other part of this is high dose vasopressor. So that means medications, the special medications that increase blood pressure. That is a vasopressor. Okay, let's rewind a little bit. Aortic stenosis. Now that is one of this patient's past medical history items. What's really important to know is, if you think back to anatomy, the heart has 4 chambers, the 2 atria and 2 ventricles, and each chamber has a door, right? It has a one-way door, it's a valve. And one of the valves that's very, very important, but can get kind of worn down as you get older, or if there's other issues that patients have underlying, they can cause the valve to kind of break down. But the most common valve that is affected as you get older is your aortic valve. Now, the aortic valve is the last valve between the heart and the aorta, the biggest vessel in your entire body. So it is the last door out of the heart, and is the most common door that breaks down in certain ways. So in medicine, we're not very creative. So stenosis means something that's narrowed. So aortic stenosis means the aortic valve is narrowed. That is the disease process that we are dealing with. Now, aortic stenosis is a very, very dangerous type of problem for patients to have, because they are very sensitive to blood pressure changes. So if you don't know someone has aortic stenosis when you're caring for them for anesthesia, you can kill them very easily with just a little propofol. The other thing to consider too is what I said earlier, was that you listened to his chest and you heard a murmur. So that is the murmur of aortic stenosis. So it is important to continue to do a physical exam, because you may not have time, because a patient comes in and needs an urgent procedure, to go and look at a echocardiogram or an ultrasound of the heart, or be able to get additional information. So you need to be able to use physical exam in order to learn about a patient's history sometimes. Now, We take our patient to the ICU. In the ICU, the patient is noted to get some blood. So I said earlier, the hemoglobin went from 14 to 10. What very commonly happens is that these patients are bleeding. So if you get a hip fracture, there's a lot of things that can bleed in your hip joint. And this particular patient lost a good amount of blood in their hip and needed some blood. So not having enough blood can actually be a problem for patients when they get anesthesia because it causes their blood pressure to be very labile or go up and down, and that can be dangerous. And in this situation, the patient received blood and they were able to come off of that blood pressure medication. So the surgeons decide it is time to go fix the hip now. So we go to the operating room, or at least plan to go to the operating room, except the day he's supposed to go back to the OR, he goes into atrial fibrillation. Now, AFib has now gotten attention because the Apple Watch can detect it and alert you on it. But what is atrial fibrillation? Now, let's go back to our anatomy lesson. The heart has two chambers up top, two chambers below. The chambers up top are called atria or the atrium. And atrial fibrillation means that the right atrium, where there is a little thing that creates the electrical activity of the heart, that one has gone completely haywire. That little electrical activity, instead of making a very nice little EKG, so you see the normal EKG up top, that like pretty squiggly line, it just decides to kind of do this. So normally the heart needs to squeeze in a very, very specific fashion, but in atrial fibrillation, the atrium, instead of doing like a nice little squeezing like this, it just kind of does this. And that causes patients to have a high risk for having clots. And if you have a lot of clots, you can get a stroke, you could get a heart attack, you can get a lot of bad things happen. So it is important for us to identify atrial fibrillation. The last thing I'd like to mention too is this particular patient is 90 years old. So anytime you have a 90-year-old heart, it tends to get tired. And atrial fibrillation is a very common rhythm problem that comes up as you get older. So we decide after assessing the patient that they've actually had a history of atrial fibrillation, that this is not a dangerous thing, and we can go ahead and proceed with surgery. So an important thing about being an anesthesiologist is knowing when it is safe to keep going or when you need more information or more workup in order to keep your patient safe and alive. So you go ahead and go back to the operating room. Your plan has changed slightly. So what you'll see in here is that the patient has gotten a peripheral IV, an arterial line, that's the same. We still plan on using an endotracheal tube, but for induction, so sending the patient off to sleep, we decide to use etomidate instead of propofol. Now, etomidate doesn't lower the blood pressure as much as propofol, but it has its own set of problems. So people are kind of plus minus about the use of it. But in this particular situation, you decide that it is the safest approach and you can deal with the side effects later. You continue to use phenylephrine, that blood pressure medication to keep blood pressure up, and rocuronium for muscle relaxation. And you're able to get the breathing tube in the patient safely through surgery. So this is what a hip fracture surgery looks like. So you go ahead and get them through that. And because they're able to tolerate that, you are able to then wake up the patient, take the breathing tube out, and take him to the ICU. And in the ICU, he recovers appropriately. Yes, so this is what's fun about the work I do, is that we get to take care of these patients in the operating room. And I also get to be the ICU doctor that takes care of these patients if they need ICU care, which in the ICU, just so you guys are aware, that means that if someone needs help with their breathing, a breathing tube, hook up to a ventilator, things like that, they come to an ICU. Another reason to need to come to an ICU is if your blood pressure is so low that you need those special vasoactive agents or vasopressors, medications to keep your blood pressure up, you need to be in ICU for that. So it's really fun to be able to see both sides of it. And one of the things that I like to mention is that as an anesthesiologist, I kind of missed being able to have continuity of care, meaning being able to see patients throughout an entire process. And by being an ICU doctor, I actually get to see a patient that comes in really sick with ARDS, is a type of syndrome that comes with COVID and other things, and be able to see them get better over time. So it's really nice to have that versus in the operating room, I only see patients like once, maybe ever. And that's something that I missed, being able to see patients longer term. Okay, that was my presentation, a little about me, a little shadowing about anesthesia, going through a simulated case. Now, as mentioned earlier, I am all over the internets in various forums. So Instagram and Twitter, my handle's at Amanda SXI at MD. And I do have a YouTube channel. So I talk about in more detail some things. You can follow me in the ICU as well. I do have a nice day in the life there. And I talk about other pathways into medicine and various things. And also the blog, you can just Google my name and you can find me there. So I'd love to answer some of your questions. I'll go ahead and stop sharing.
All right. Well, first of all, thank you so much for that. We went through cases. We went through just in general anesthesiology as a specialty. Definitely insightful. A lot to take away there. I personally learned a lot. We do have a few questions, so I guess we can just get started off with them. Our first question is about just in general why you chose anesthesiology. Our student here is asking, what made you chose anesthesiology as your career choice? And when you were making that decision, did you have any different specialties in mind that you were also interested in?
That is a great question. So I will just say that I'm going to give you guys the short answer now, but there's a very long answer version of this on the blog because I started my blog like over a decade ago. So when I started medical school in 2011, I actually wrote an entry like very, very frequently to explain what some of the things I was considering. So when I went into medical school, what I'll tell you is before I started, I was open to anything. I came from a non-medical family, so I had no exposure to any of these specialties. No one in my family is in medicine, period. And so all I could really figure out in terms of exposure was the shadowing I did, some of the work I did as a biomedical engineer that gave me a little exposure as well. But generally, I didn't really know what I wanted to do. Before I started medical school, I stumbled across an anesthesiologist named Dr. Michelle Au, and she wrote a blog, and she also made these really cute comics. And I explored her blog and actually read the entire thing through. And I was kind of inspired to at least check out the field of anesthesia because she had transferred from a pediatrics residency into anesthesia. So I said, oh, that sounds kind of cool. But once I started medical school, I was like all over the place. I was like, oh, what about clinical genetics? Or I could do cardiology. So I actually worked as an engineer on the heart lung machine. So I was like, oh, the heart seems like a really cool organ. Like, why don't I do that? So I like literally liked everything. Third year of medical school. So they've changed this now. In certain medical schools, the curriculum is a little different. So instead of doing 2 years where you're in the classroom and 2 years where you're in the hospital, now a lot of medical schools are doing kind of 1 year or 1.5 years in the classroom and then more time in the hospital. But my med school was more traditionally based. So it was 2 years of in the classroom and 2 years in the hospital. So the third year is generally when you're in the hospital doing rotations, getting that real hands-on exposure to different specialties. There's required specialties for every single medical school that you have to rotate through. So those are things like primary care, family medicine, internal medicine, pediatrics, surgery, and neurology, psychiatry. So those are some of the like basic specialties you absolutely have to get exposure to. But things like anesthesia, ophthalmology, dermatology, like radiation oncology, radiology, those are actually specialties, or pathology. Those are all specialties that many people have to know or have someone to kind of introduce them to in order to check out. So I went into third year thinking that I would want to do OB-GYN actually, because I was a big advocate for women's health. And I thought OB-GYN was like the best of everything because I thought the operating room was really cool when I did surgery, but I didn't want to be a surgeon. But the clinic is also really cool because that means I got continuity. I got to see patients all the way through their, you can see patients like in OB-GYN, you can see teenagers for their birth control all the way up to them having babies throughout menopause. So it's a really nice continuity of care there. But then I got to my OB-GYN rotation and I found that it was the worst fit for my personality. It just wasn't the right place. And one of the things that you learn when you go through medical school is you want to find your people. You want to find people who think the way you do, who really show things that are aligned with kind of your interests, and it has a culture that aligns with what you want. And I found in OB-GYN that was not the case. It was a very poor fit for me. So luckily, my medical school allowed us to do specialty rotations during our third year, which is not usually common. Usually I have to wait till fourth year. But I got to do an anesthesia rotation during my third year towards the end, and it was a very good fit. So what that meant for me was that I found that the people I worked with were very, very cool, calm, collected, totally able to handle really, really, really stressful situations with a level head. These were people that were really, really into the team-based approach. So this continues on to this day. If I'm in the operating room, I need an extra set of hands. I call one of my friends in, they come in, we get things done. And it's just an incredible kind of environment to be in, to know that you have all these people that are there willing to help, that you have colleagues that way. And it also is really cool that I get to be in the operating room, get to formulate these relationships with the surgeons, create a mutual trust, but not have to be a surgeon. That's the thing, is they always say, you choose another specialty if surgery is like the only thing you could ever do, then become a surgeon. But the reality is surgical training and the lifestyle of a surgeon is harsh, and you have to really want to do that. But I didn't want to do that, but I like the operating room. So that was the one area that was also really important to me. And once I went through some of my other rotations, I realized that they didn't really give me that same kind of fit. And I also love that an anesthesiologist is like the most useful person on an airplane for a medical emergency, because literally we can do like everything, right? I don't rely on anyone. So one of the things that most people don't realize is like doctors like don't know how to start IVs. That's not a part of medical school, right? That's typically not a big thing for us, but anesthesiologists are great at placing IVs. We can go ahead and draw up medication. So we are nurses, we are pharmacists, we are doctors. So it's really, really a useful thing that we're able to do all of that and manage airways and kind of just manage patients overall. So that was something that I thought that was really, really cool. And yeah, so I considered a lot of different things, but anesthesia was the best fit.
Definitely a kind of a thorough investigation of the specialties there, and seems like it was definitely the right choice. Another question we have about just the day-to-day life. Do anesthesiologists also do PICC lines along with the work you mentioned earlier?
Oh, that's a good question. So generally PICC lines are placed by nurses. A PICC line is also a central line type of thing, but it is something where they've created a device that is really, really makes it a lot simpler for them to place it generally up in the upper arm here. So it is generally a nursing based thing that's placed.
Okay, I see. A really relevant question. This is probably on the minds of a lot of pre-meds, especially as the application cycle nears this summer. What was your why when you applied for medical school?
Ooh, I will tell you that I am embarrassed of my personal statement if I look at it right now. So one of the things I will say is that everyone's personal statement and your like why medicine is going to sound pretty similar. So I interview students for my medical school. So I have heard the answer to why medicine many, many, many times in many, many, many different flavors. And that is okay that it sounds very similar. But the most important thing is that you show us and demonstrate that you have really explored everything, that this is a good fit for you, and that you understand what it is to become a physician. Because why medicine is not really the question, it's why are you going to become a doctor? Medicine encompasses a number of team members. So, you know, nurses are also in medicine, PAs are also in medicine, AAs are also in medicine. So I think it's going to be very important to distinguish why it is that you want to become a physician, not just why medicine. You do have to answer the question of why medicine, but there are certain differences in the training pathway and in the malpractice litigation pathway and just the overall debt that you will encounter as a physician. And so being aware of all of these things and being able to articulate to us that you understand that that is the case will be very, very important. So my why medicine was really that I could not see myself doing anything else because I always wanted to care for people. That's always been one of the things that was important to me. And I demonstrated through various areas of my resume. So to back up, like when I was an engineer, I did a senior design project on a device to identify bleeding early in a interventional cardiology procedure. So I got to talk about how that kind of work was really important to me to be able to think about those patients that I'm impacting and be able to influence lives in that way in a positive fashion. I also just talked too about the fact that I had considered many other pathways besides becoming a physician, besides medicine as a whole, and identified reasons why those things were not good fits for me. So things like I worked as an engineer actually for a short period of time, and it was a terrible fit for my personality because I was sitting at a desk all day. I didn't feel challenged. I didn't feel like I was able to actually influence and make a difference. I didn't feel like I was really using the knowledge that I had to the fullest extent that I could. And I also didn't feel like I was a part of a team, or that I was able to really find value and gratification in the work I was doing. So there's a lot of things, there's a lot of different ways to articulate why medicine, but oftentimes when we're looking at your application, it's to identify that you understand the rigors and the path that you're about to embark on.
Definitely a lot to say in that question. It's kind of loaded, but seems simple in the beginning. Another question we have is over the care that you provide for patients. So after you go through, it seems like they're referring to just the initial process. You mentioned induction as being really when you're the most involved in the beginning. So after providing that patient anesthesia, do you still have to be kind of fully attending and in the moment the whole time, or do you pass it on to someone else to look over them?
So what I'll say is the practice of anesthesia in the United States is different than the practice of anesthesia in other countries. That's another thing to consider. So in the US system, there's a lot of different ways anesthesia can be provided. So I kind of alluded to earlier, like I myself can sit there and provide anesthesia the entire time. That means that I will go see my patient beforehand. I will place my own IV. I will go into the operating room with the patient. I will be there to provide medications or induction, send them off to sleep, put an airway in, kind of just sit there the entire time and monitor their vital signs, give pain medication, do all the things that we would do for anesthesia to get them through surgery, and then wake them up and take them to recovery. So that is, I could do the entire part of that. Or because of various billing. So here's the thing, in medicine, you have to make money. Otherwise you can't really have a hospital, right? So there is a component of how do you make money for a hospital? And in a billing situation, it is oftentimes most lucrative, if I'm not doing the anesthesia myself, to have other people that are there in the rooms as well. So we'll have one anesthesiologist, myself, and overseeing having a nurse in the room and a resident in a room. So that, but there always has to be an anesthesia person in the room at all times. That's one thing that I want to make sure is very clear. The other thing is this whole idea of like flying a plane. So obviously when we're on autopilot on a plane, it actually is pretty similar to anesthesia. Once we have gotten a breathing tube in or, gotten some other device in, once we've gotten started with the surgery, certain surgeries are less dangerous than others. So the less dangerous procedures that happen, yes, we can kind of sit there and like more passively monitor everything and have conversations and do all of that. And, on TV, you see people playing music in the operating room. Yes, we do play music. Yes, there is conversation and talking and telling each other about our days in a very, very kind of low stress room. Now, I do things like vascular surgery. So I recently, for example, I had a case where we lost 40 liters of blood. You yourself as a male, let's say like a normal adult male, has 5 liters of blood. So if you think about it, we lost 8 times that patient's total blood, all the blood in their body. We lost it 8 times and we gave it back. So that's a type of procedure where I was there for 16 hours and I sat down like twice, maybe, but I was there the entire time. And we had always 2 to 3 people in the room at any given time managing that patient. So it really just varies on the procedure and the type of thing that's being done about how like present I am. But yeah.
Wow, definitely a great story to hear. Another question we have is over your past with medical school. So you mentioned that you pursued a degree in engineering before going to medical school. Were there any challenges you faced by choosing that kind of unconventional path to medical school?
Oh, that's a great question. So I love talking about paths to medical school. So number one, I'm going to say is the early college. So transferring in college in general can be very challenging, because for your medical school application, you don't have as many like longer term leadership opportunities. You tend to have to like restart and reinvent the wheel when you go to a new school. So that's one thing I like to bring up, that transferring sometimes can force you to need to do an extra year, which is what I did with my master's degrees. I maintained one extra year at Michigan so I could have some really, really profound and like legitimate leadership experience and research experiences that I could add to my resume for that year. Another thing to consider is engineering. So I'm a very practical person. I do like to at least emphasize to you guys is be prepared about finances. Like you have to understand the finances of what you're about to do, because some of my colleagues have come out of medical school and residency $400,000 to $600,000 of debt. And that's only going to go up for you guys because of inflation and the increasing tuition costs and et cetera, et cetera, et cetera. So you have to be mindful of that. And I think it's important that people don't talk about enough is that I actually got a scholarship to medical school. It's a real thing. You can get scholarships. And that was a huge financial, it eased a lot of things financially. And you can't just rely on like public service loan forgiveness, which people love to think, oh yeah, I'll just work in this nonprofit, blah, 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 for 10 years. 10 years of your life is a long time. So just think about finances. Anyway, the engineering part was because I'm very practical and I was scared I wasn't going to get into medical school. So a biology degree did not offer me a job, but an engineering degree offered me a pathway that allowed me to get a job. Hence, I got a job and then I got off waitlist. So just to give you a little background on the pre-med part, I applied late. Don't do that. Don't apply late. Apply on the first day. That's like the most important advice I can give you guys. Get all your secondaries in early, obviously, because your chances of getting an interview when you apply that early are much higher than when you're like me. I applied like my primary was in August. And my secondaries were in like November, December. Not great. So it's amazing that I got anything. So I ended up with 4 interviews and I ended up at the end of it with 3 acceptances, but my first acceptance didn't come until May after I had applied. And my University of Michigan graduates in April. So I was like, I don't have a place to go. So that's why I got a job as an engineer. And then I got my acceptance as I was working full-time as an engineer. So that's kind of the whole, like, why did I become an engineer part? The other thing I will say is the challenges of the non-traditional part, besides the transfer thing, the engineering route will lower your GPA. That's just any good engineering school. Like a 4.0 is not as simple in an engineering degree as it can be in some other degrees. And that is a real problem. So you have to be careful about that balance. You have to be able to work really hard. And I will say I'm lucky that my 2 years at the liberal arts college actually buffered my GPA substantially, because I got like some sad looking grades when I got to engineering school. So even though I came out all right, I definitely saw a bit of a decrement in my GPA because of the engineering degree.
Yeah, definitely another interesting story behind there. And actually, we just have another quick question over medical school. In regards to post-acceptance. So for people who have been accepted, some people just feel the urge maybe that they need to prepare from your end, having gone through medical school and even now as an attending, do you have any advice for people who have been accepted into medical school, what you would say are the most important aspects to focus on?
You don't need to prepare for medical school. You're going to be literally spending the next decade of your life doing medicine. So my recommendation is not to prepare for medical school. That being said, because all of you guys are type A and we're all perfectionists, if you really want, I would say that what's really nice is to be able to take the time and do the things that make you a little more well-rounded before medical school. So it's just one of the last times you'll be able to just like, not to say you won't have time to read fun books, but honestly, like the next decade is going to be medically related things. And that's just the reality of it. So there are times when there's breaks, like in medical school, to go on big trips and be able to really explore hobbies that fill your cup up and that are really important to you, but it's not going to be the same. So once you start off on the path, like once you start medical school, you will find that your identity changes and that you suddenly are you like live, breathe medicine, and it can be very challenging. And so I think a lot of the people that I know personally, and myself too, feel like it's important to try to protect that identity before you start, like the things that you love and you're passionate about, and really do all of that. Because once you start, it's 10 years before you get to maybe see a little more kind of light in terms of time to do those things again. So that's what I would say. I wouldn't go try to read a textbook. Like, that's why you're going to medical school, so that you can study medicine. Like, don't do that before you start. Once you get like all your book lists and your schedule and stuff like that, you can start worrying about it then. But seriously, like, do not try to read medical stuff before medical school, especially if you're accepted. Like, it's fine. You're going to do that for like the rest of your life.
Yeah, definitely some good advice there. Just taking a break once in a while doesn't hurt. And actually, wrapping up the end of the hour, I think we just will cover 2 more questions. I just do want to say though, we have had a couple of people saying thank you. So we just want to also pass on our thanks to you. It's really been a great time, and I can tell that there's a lot more that you have to say about advice for medical school, just the general specialty of anesthesiology. So anyone who wants to hear more from Dr. G, definitely go on to her blog, her YouTube channel. There's a lot more resources over there past this hour of shadowing that you can get from her. But just to wrap up for our session today, we have 2 last questions. The first of which is about, what do you do when, as an anesthesiologist, you're having difficulty with intubating a patient?
Ooh, that's a really great question. So there is a designation on the chart, or anesthesiologist, when we hear the terms difficult intubation. So some patients will actually have had an anesthetic in which an anesthesiologist has attempted and has failed potentially at intubating, so that they get a flag called a difficult intubation. Patients will also get a letter home so that they know that they need to come again if they ever get anesthesia again, that they come with this letter so that they're prepared, or the anesthesiologist and the team can be prepared. What I will say is that a difficult intubation 20 years ago was very different from a difficult intubation now, because because of the invention of video laryngoscopy, it's a lot easier to get patients intubated than it used to be when we just had a blade to use. So that's one thing I will say. If we do encounter an unexpected difficult intubation, what I'll say is the first question is, can we mask a patient? So that is a skill that you guys will learn when you go through medical school, and that we really emphasize, because if you can mask a patient, you can keep someone alive. You don't need to learn how to intubate someone, but you do need to learn how to provide appropriate mask ventilation. So that's one area that's really important. If we can mask a patient, we have all the time in the world and we can get all the fancy equipment in. If we cannot mask a patient, then we're going to be thinking about, okay, what do we have available? And do we need to do a surgical airway? So that means, do we need to cut the neck and get a direct hole into the windpipe in order to put a tube in there if we can't get it through the mouth? Typically, a patient population that we can encounter that this could happen is really big masses in the mouth or in pharynx, things like that. We can have patients with cancers there that may get totally occluded in the mouth to be able to get in to the airway really easily, or identify where the airway is. And another patient population is ankylosing spondylitis. It is called the bamboo spine. That is a type of disease process that will scare every anesthesiologist, because the neck doesn't move. And if a patient's neck is so stiff that literally you like try to tilt their head back and their whole body goes back, we see this all the time, but it is a frightening airway test. So what our like gold standard for a difficult airway is a fiber optic scope. So that's basically like a long camera with a little, like a camera at the end and a light at the end, and then using video with it. So if we can't get it with those 2 things, then we're going to be talking about cutting the neck and putting a tube directly in.
Yeah, that airway is really important. So doing what you can to keep the breathing going is, I guess, the main goal. One last question about emergency situations. So in an emergency situation, when a patient maybe has cardiac arrest, for example, and there's a lot of doctors on the scene, how do you take the lead over directing CPR? There's so many people there, and it's kind of a chaotic scene. How does the organization fall in place?
Oh, that's a really great question. So I'm going to just divide that question into different areas though. So if there is someone who undergoes cardiac arrest in the operating room with an anesthesia team there, then the anesthesia team is going to direct that code. So because the anesthesia team, one, has all the access, that means all the IVs and ways to provide medications like epinephrine, be able to call in people to do CPR, et cetera, et cetera. If we're talking about a situation like in a hospital room, like so a patient unexpectedly undergoes a cardiac arrest, and generally what will happen is, because I'm also an intensivist, I show up to those things, to those codes. Generally, we are the ones providing an intubation, but sometimes there may be some additional things that are overlooked by the team that is running the code. And I will oftentimes help provide some of that guidance and provide suggestions to the team. But generally, people come in with different roles. So on the floor, on like a regular hospital floor, there's usually a code team that will be in charge of, you do this, you do this, you do this, and other people will come in and help with their tasks. In the operating room, like I said, it's very different. Usually an anesthesiologist will be the one that is running the code because they understand the patient's history at that point. And generally a surgeon is going to be, they're a proceduralist, right? So they're the ones that are not really focused on what's going on with the vital signs and other things. So they can be helpful in like CPR or like making sure to close off whatever needs to happen if we need to close things off. Or if this is like a cardiac case and they go into cardiac arrest, then like they can like literally just squeeze the heart and give it a massage or shock it, et cetera, et cetera. So it's a little different depending on the environment in which someone is coding.
All right, well, I think that really wraps up our questions for today. Again, a very insightful session overall, from the talk to the questions, your responses to them. Definitely thank you so much for joining us today, Dr. G. And for our shadowers listening in, just a last reminder, we have our quiz. We have had a few issues with posting it into the YouTube comments, but I believe it has gone in. And also, in terms of the main way to access it, in case there's any problems with the chat, you can access it through our virtual shadowing page. And the quiz will be due at 11:59 p.m. Central Standard Time, as usual. That's going to vary if you're on the East or West Coast, but just adjust it to Central Standard Time. It's going to be due on Wednesday, February 2nd, next week. And after passing the quiz, you're going to receive a certificate based on the email that you listed on that quiz. If you don't receive the certificate, just check your spam folder. And next week, we'll be joined by Dr. Smith on Thursday, February 3rd at 7 p.m. Central. So definitely stay tuned for that. We actually just have one more question that just popped in, if you don't mind, about your most interesting or memorable case. Do you mind going through that quick?
I think the most memorable case is probably the most recent one that I had, which unfortunately the patient did not have a good outcome. But what I'll say is I do vascular anesthesia, and I alluded to this earlier. The aorta is the biggest vessel that comes off of the heart, and vascular surgeons do work on the aorta. So the anesthesiologist has a lot of work to do when it comes to being able to put big central lines in, being able to give a lot of blood, be able to give specialized medications to keep blood pressure up or down. And the other component of that is this particular patient arrived to us very, very sick. So things like this patient had an overwhelming blood infection. They also already were on steroids. So that meant that they were immunosuppressed. Their immune system wasn't working properly at baseline. Patient had problems with their lungs already. The other big thing is that when you're in an ICU, it's very common for older patients to get delirious. Even young patients can get delirious too, but basically that confusion, that is another component of it. And so what was memorable about this particular case was just that, one, it is such a specialized case that, you know, we have only done 5 of this type of surgery in the last like 2-3 years. And I was able to do the anesthesia for 2 of those 5 cases. And so that is something that is like very memorable. The first one I said earlier was with the 40-liter blood loss. This particular one was only a few liters. So it actually is a lot. A few liters is not common under surgery for surgery, but it's less than the really big one. But I will say that what's tough is that you will not always have good outcomes. And that's what's really, you know, those patients stick with you. these patients stick with you forever, and they make you ask yourself, what could I have done differently? Could I have predicted X, Y, or Z thing happening? How am I going to take this with me to the next patient? And I think the other important thing to just bring up is that in medicine, because there are sometimes not great outcomes, you have to be able to figure out how to separate your involvement in there, or how to not blame yourself for things, and not how to like feel guilty about it, even though, like I said, we're all going to be a bit type A or perfectionist like, and it can be really hard not to blame yourself or kind of hold that with you. So that's just kind of an overview of like that particular situation, that why it was memorable, the case type, the outcome, some of the things that we had to work through in order to make sure to keep the patient safe. There was just a lot of considerations for this particular patient. Like, we did dialysis in the operating room, so we have to kind of set that up. We had to do one lung ventilation. That means literally we're only giving oxygen and taking out CO2 from one of the two lungs there. And so there's a lot of really interesting physiologic and other anesthesia related things for that case.
Absolutely. I think that's a great kind of question to end off on. Again, for those wondering, the quiz is available on the chat, but if in case you're not able to see it, go to our virtual shadowing page. It's available kind of under the button that says shadowing quiz. I believe Dr. G should be titled as that. If you have any questions, though, email us at shadowing.h4h@gmail.com. Again, thank you for Dr. G joining us in. I'm not sure if we mentioned her Instagram. I think we did. Amanda's GMD, right? That's her Instagram, so definitely follow her there. I think that really wraps it up. So